I think that adherence is the major problem we have in long-term treatment of schizophrenia. I think the drugs we have available are all pretty well working, but the big problem is that sometimes due to the side effects, but sometimes also related just to human nature of forgetting to take pills. In almost all cases, our patients struggle with the challenge of staying compliant with the treatment. And I think this challenge is very often underestimated. Although most colleagues are absolutely aware of the fact, it is seldom taken into account in the long-term treatment. No, I think it's also very well shown in literature that it starts right away. When we think, for example, about the work done by Jari Tihonen in Finland, we saw that in first episode, patients suffering from schizophrenia for the first time and discharged after their first hospital stay, we saw that more than 4 out of 10 discontinued antipsychotic treatments straight away within 30 days. And I think this very nicely illustrates that the problem is there from the beginning, also in our first episode patients. No, of course it's not. There are very good review articles, one just recently published by John Kane, showing that in all kinds of somatic diseases we have that problem. Plus, for example, if you take into account also recently published review article about oral contraception, there was a big difference in the Pearl index, so the efficacy of contraception found under naturalistic conditions with 8 females becoming pregnant over a year compared to 3 out of 1,000 in controlled trials where compliance was taken care of. And I think that nicely also illustrates that non-compliance or partial compliance is a problem for everybody. So we cannot narrow it down to our patients only suffering from schizophrenia. I think that long-acting antipsychotics are one option to help our patients stay more compliant, but mostly the effect of long-acting antipsychotics is that they make partial or non-compliance transparent to the treatment team. So there are only a few studies showing actually that there is a certain switch or change in the compliance rate in patients when they are started on a long-acting, but what you see is that the team can act on emerging partial compliance or non-compliance and help the patient back into the boat. And I think that's how long-acting injections work. On the market in Germany, of course, we have the conventional, so-called conventional first-generation antipsychotics like fluphenazine, haloperidol, but also flupentixol, not available in all countries. From the newer generation, we have risperidone, we have polyperidone, the metabolite, 9-hydroxyrisperidone, olanzapine, and arriving shortly to the market will be aripiprazole as well. It's rather problematic to break this down to actual concrete numbers in Germany. We do not have a register where we can directly link prescribed medication to the underlying disease. So what we roughly know is that the current prescription rate with long-acting antipsychotics is around 17 to 19% in Germany, which by far undergoes the acceptance rate on the patient side. I think that psychiatrists think twice or even more times before they offer a long-acting compound to a patient. And most often the drivers there are patients having relapses in the past quite often, patients showing more or less overt phases of non-compliance in the past, maybe also patients where the psychiatrist sees a risk in the direction of committing suicide or a hazard risk for others. That's an old stereotype, we know. But there is also, very interestingly, another cluster of patients where doctors say they might actually qualify very well for long-acting treatment. Patients who are described as open to drug treatment, having a good therapeutic alliance, maybe in their early stages of the disease, but we speculate, it's only a hypothesis, that these patients are exactly those ones who are seldom offered long-acting. The doctors think that they are candidates, but they rarely offer it. And the group of patients who are offered is below 35% in Germany. I think that gap between knowing and doing is found in a lot of fields. And as far as we could do research on that, we found out that doctors might sometimes fear that it's an action of more or less accusing the patient of having been non-compliant, of undermining the therapeutic alliance with them as the doctors. And so doctors, mostly in the private practice sector, step back from that and don't want to accuse. Also, they think that the acceptance on the patient side is very low, which is actually not the case. Plus, doctors are not good in predicting who might be interested in long-acting and who will not be. And so our approach is always to recommend to at least offer long-acting as one option to 100% of the patients suffering from schizophrenia or schizoaffective disease. In those patients, I think the focus is clearly different. I think in those patients, we have to look at recently available very good study outcomes coming, for example, from Robin Emsley in South Africa, who nicely showed in a study that explicitly that group of patients does benefit a lot from long-acting because you can shelter them from their first relapse. And we know that every relapse, not in general, but in almost all of our patients, has a negative impact on the future course of the disease. And also from imaging, we know that in the very beginning, changes in the gray matter and also white matter of the brain start from the first episode. So relapse prevention in those first episodes seems to be key. And long-acting does a very good job. But this just recently became newly available because in the 90s we did not do any research in our first episode patients with long-actings because we treated all of them with oral second-generation compounds. And so we had a gap in our literature-based knowledge. But now it's filled again, and now we should use it again. That's problematic because very often long-acting is discussed in the context of stigmatization. And this, I think, has to be strongly viewed in front of different cultural backgrounds. In some countries, there might be the overall notion that treatment with an injection is something very effective, even considered to be a better way of treatment. While in other countries, this might be an indirect sign for the patient or the family that the treated disease is actually a very highly severe one and might fall back on the family as a sign that somebody suffers of a real bad disease. And they might even feel ashamed. So we received mixed reports from different countries about that aspect. I think stigmatization can be best encountered by educating people in general and also by causing as little long-term problems for our patients, like long-term tardive dyskinesia. And I think we can do a very good job with modern long-acting antipsychotics in that direction. Yes, of course. That's true. We started that about 5 to 6 years ago, and it was an offspring from another project we had started actually 2 or 3 years before, where we explicitly focused on doing everything to help our patients stay compliant with antipsychotic treatment in general. But then we saw that we were a bit successful with what we were doing there, but we could do even better when we combine those techniques of psychoeducation, social treatment, family treatment, together with long-acting injections, simply to track compliance better
Yes.
As I said, it only makes partial compliance more transparent to the team. So we combined that, and this was the starting point of the OASIS project. OASE is the German word for oasis, and at the same time in German language it's an acronym for Optimized Ambulatory Outpatient Treatment of Schizophrenia. This does not work in English language, so we always address it as the OASIS project. And what we do there is simply combining long-acting treatment with all those other interventions we offer to the patient to help the patient stay in the treatment boat. And this is quite powerful, and we can reduce relapse rates and inpatient stays over the time of that project. The idea behind it was really, just to add that we wanted to get long-acting away from that dark side of the treatment, you know, because a lot of patients in the 90s were treated with long-actings when everything else was tried before and nothing really worked, and they were always the last in the row. And we wanted to change that, and we also wanted to change the whole scenario a little bit, and so we thought OASIS might be something very positively connotated, and that's why we chose it. So I'm glad you like it. Yeah, sure. I think that the pipeline, talking about new compounds, is somewhat promising, but also somewhat disencouraging. So we all speculated about glutamatergic drugs coming on the market and maybe changing our compound arsenal we have for helping our patients with negative symptoms. This did not turn out to be ultimately true, so far at least, but there's drugs on the horizon. Maybe they will help a little bit. We will get one new long-acting injectable, that's going to be aripiprazole, which is a good new choice of long-acting drugs. Plus, I do think that we might benefit from optimizing our non-pharmaceutical, non-pharma treatment strategies in optimizing adherence. So I think there is a lot to do. What I view very, let's say, at least debatable about our guidelines is that so far long-acting injections have been quite neglected in our guideline recommendations, coming from partly not real good level of evidence available to corroborate the recommendations, but also that long-actings are only viewed as the very last step in an algorithm of treatment. And this is not justified anymore. And I think hopefully guidelines will catch up with that and change in the next years. Well, this is a very interesting study because it was done quite naturalistically. As far as I can tell, those study results have only been presented on posters. So I'm always very careful in interpreting that. I think it was very well chosen, and also the primary outcome of that study, not focusing again on PUNS changes, I think is very well chosen because for a long period of time we have only focused on PANS and psychopathology and changes there. So I think that functioning studies are very meaningful. And so I like that primary outcome. But I hope you accept that I will not speculate on the final outcomes as long as we have not reviewed articles on it. And so I'm looking forward to that together with you.